Good afternoon. I'm Steve Selbst, Quill Healthcare Consultant, and I would like to introduce my colleague, Ms. Regina Vasquez. Regina, say hi.
Hi, everyone.
Well done. Between us, we have over 30 years of healthcare consulting experience, and we specialize in payer contracts analysis and negotiations, credentialing, claims tracking, and marketing practices services to payers and employer groups. Between us, we have negotiated over 10,000 payer contracts. I am pleased today to welcome you to Quill Healthcare's 8th monthly value-added webinar for practices. Quill Healthcare is the leading seller of medical supplies and office products and is dedicated to providing you with useful content in these webinars as a value add to your practices. Today's topic, 10 best practices to assure and accelerate patients' payments, is presented by Mr. Rajesh Bodaraju and Mr. Thermal Nalutla, co-founders of HealthyPass, a revolutionary patient payment system. Now, before we begin, I would like to cover a couple of quick administrative matters. A number of you who have been to prior webinars are familiar with this process. However, we do typically have a large number of new attendees, so it's important to make sure everyone knows how they can participate so that we can enrich this session for all attendees. First of all, at any time, starting now, you may send any question that you may have to info@healthsense.com as displayed on the screen. We do prefer that you correspond via this email ID rather than trying the instant chat session, since we may or may not be able to see your chats come through during the session. It is best to send all questions real time to info@healthsense.com, and my colleague Ms. Regina Vasquez will monitor those questions throughout the session. And when Rajesh and Thermal pause for questions, Regina will have gathered your questions and will ask any questions that come through. So please do not hesitate to send any and all of your questions to info@healthsense.com as displayed. Further, during pauses, you have the opportunity to ask your questions live. To do so is very simple. I will open up the lines, and at that point, you may simply press *6 on your telephone keypad, ask your question, converse with our featured speakers, and when you're done, just simply press *6 again, and that will mute your line. So that is how you go about asking questions. Either send an email starting now to info@healthsense.com, or during our breaks, go ahead and press *6 on your phone and jump right in and ask your questions. We invite questions of all types. That makes it interesting for all participants, and it enriches the session because we're able to really target the session specifically to meet your needs. So we look forward throughout this session to answering your questions. You may also, at any time following the session, send an email to that same email ID, and we will pick up your questions there. Additionally, if at any time you lose contact with the web portion of this session, simply go back to join.me/healthsense, and you'll be immediately joined back into the session in your web browser. So no need to worry if for some reason you lose connectivity for any reason whatsoever. It's easy to get back in. Just keep the telephone line going and go to join.me/healthsense. And if you lose phone contact, simply dial back into the phone session as well, and you can pick up right where we left off. And following the session, within 24 hours, we will typically have our copies out there for you along with the recording. In fact, the copies are out there right now. The recording will take a little bit longer than the 24 hours. So you go to healthsense.com/copies, and you fill out a very short form, and you immediately get all of the information related to this webinar, including a complete recorded session as well as copies. So It's often a question on the front end is how do I get copies? That's how you get copies. Now, I would like to introduce our two featured speakers, Mr. Rajesh Boddaraju and Mr. Thermal Nalutla. Rajesh is an accomplished entrepreneur and angel investor in healthcare and technology ventures. In fact, Rajesh's most recent venture, CVM Solutions, grew from a bootstrapped concept and idea to being named by Inc. magazine as one of the 500 fastest growing private companies in the U.S. Rajesh is the founder, president, and CEO of HealthPass Inc., HealthyPass Inc., a revolutionary solution to virtually guarantee patient payments for ambulatory care groups. HealthyPass is a digital check-in and patient payments platform that turns patient bad debt and all expenses associated with patient billing and collections into higher operating income while delivering an outstanding patient experience. HealthyPass has won recognition during its launch from trade publications such as Becker's Hospital Review and Crane's Chicago Business. Mr. Thermal Nalutla is a distinguished technology executive with over 24 years of professional experience in the design, architecture, and implementation of large-scale IT systems, and he has helped clients across various industries, including healthcare, retail, distribution, e-commerce, as well as other industries. He has worked with some of the industry's most prestigious companies, such as IBM, Deutsche Bank, and he is proud to be part of the launching of India's first supercomputer. He has been recognized as a worldwide leader in cloud-based computing and featured across several speaking engagements. Thermal is a renowned inventor. He has authored in several publications, and he has many patents to his credit. No doubt, these two gentlemen together can certainly provide you over the next hour and a half with a lot of useful information about how to maximize your patient collections, which in turn is going to increase your revenues. And I would encourage you as well, if you didn't have the opportunity to attend last month's session, at the end of this session we'll be providing information how you can view that topic, because that's where we talked about how to maximize revenue on payer contracts. So this is yet another piece of the revenue cycle puzzle, and a very important piece, as you will learn, because this portion of the revenue cycle is becoming more critical because there are much higher percentages of patient payments as the Affordable Care Act is rolling out. So this could not be more timely, because this will help you and your practices to attain additional revenues. So without further ado, I am honored and delighted to turn the floor over to Mr. Rajesh Boddaraju. Rajesh, take it away.
Thank you, Steve. Thank you so very much for those kind comments. Good afternoon, everyone. It is a pleasure to meet all of you virtually today. What Steve did not cover in the introduction is that I come from a large extended family of physicians myself. In fact, 5 out of 8 in my immediate family are all physicians. I'm also an investor in a chain of immediate care clinics, so I've had firsthand experience over the last 5 years or so being involved in immediate care clinics in terms of patient payments. And besides the two of us, and including our third principal, combined the principals at HealthyPass have 35 plus years of experience in healthcare in a variety of settings. So I'm very eager to share some of our learnings, hear your perspectives and questions, and try and make this very interactive as much as is practically possible on a web session like this one. So real quick, I think we've broken this afternoon's topic into 2 logical segments. The first will share some insights with you related to patient payments. To keep this interactive, we've actually put in a couple of polling questions that Steve and I will share with you, so that we actually encourage participation from all of you guys. And the second one will be the 10 best practices as we have observed leaders that have done a great job around patient payments, and share with you some of their insights from and learnings from their practices. Each of these sessions, we will pause towards the end for a open Q&A session that Steve has alluded to. So you'll have an opportunity to ask questions, comments, any thoughts are also very welcome. I'm also eager to learn from you guys since you guys are in healthcare and you practice and see this day in, day out. So I think it'll be good to keep your participation as much as possible. Next slide, Steve. Well, this is certainly, I can say, an unprecedented time in the history of healthcare, and of course, a lot is going on, as we all know, in healthcare. The very first broad theme that has emerged with all the change that is going on in healthcare is the fact that the patient's skin in the game continues to be a very, very important tenet of all the changes that are occurring in healthcare, whether it be new insurance plans offered by payers, whether it is the plans that are offered on the ACA exchanges. But the reality is, the patient's skin in the game as a way to contain cost is here and is here for real. And you'll see that in the type of, enrollment stats that we are seeing across the board, and particularly, in groups that are employer-sponsored as well as individual plans that are offered on these exchanges. And obviously, the basis of this is, the all-you-can-eat buffet style of plans encourage people to use healthcare more, and therefore, as you see this patient out-of-pocket increasing, it's really a way for both the government as well as the commercial insurance companies to try and, contain costs. The second thing that is going on is the fact that the financial risk is actually shifted from insurance companies that were supposed to take the risk to all of us as providers, and I say us because I said I'm directly impacted being an investor in a chain of immediate care clinics. But you are beginning to see a substantial amount of the financial risk come to you as you and us as providers, and that's the second broad change that you see in healthcare today. The third thing, of course, continuing down this, the thought process of financial risk shifting to providers, is you're seeing a lot of discussions and a lot of experiments, I will say, to move away from fee-for-service to fee-for-value, value-based reimbursement plans, including things like bundled payments, ACO models, various levels of capitation-oriented contracts, and all of which continue to threaten both the volume as well as the top line for all of us as healthcare providers. Among this shift, also importantly to note, is the fact that a lot of the large health systems have begun and continue to consolidate, acquire mid-sized practices, ambulatory care settings, so on and so forth. And you're seeing the play from these large health systems in terms of being able to cater to this type of arrangements where they may contract out with large payers to be able to handle a large population of subscribers around things that are slightly different from the world of fee-for-service that we all live in. When you look at how it impacts ambulatory care practices, group practices that many of you are part of, one of the things that you're also seeing today is rapid innovation around the clinical care delivery model itself. For example, the wearables industry with, the Apple iWatch to Fitbits to all the different types of wearables that are coming into play. You're seeing significant innovation across even things like lab testing and diagnostics. Take, for example, a company called Terrano that some of you may have heard of. With a single drop of blood, they are looking to do an extensive amount of testing that was really not even possible before. And that's, again, one simple example of the type of innovation that is occurring across the clinical care delivery itself. In addition to all of that, you're actually seeing nurse practitioners' lines, telemedicines, retail clinics everywhere. And my point of all of that is when you think about the traditional medical group practice, all of these type of innovations that are going on across the entire spectrum of clinical care delivery are all beginning to threaten, I'll call it, both the volume of patients that a particular practice might see, as well as the type of services that are going to be performed in the traditional clinic or the traditional group practice. And of course, that has a very direct impact to both your top line as well as your bottom line. And of course, not to forget the significant increase in regulatory compliance, whether it is meaningful use and all of the standards that have been laid out as part of the Affordable Care Act, or even the transition that is imminent now from ICD-9 to ICD-10. And all of this, of course, means that we are going to incur additional costs that continues to put pressure on an already thin margin that most health systems and most healthcare providers kind of operate in. So with that backdrop, what I thought we could do is just to get get you guys a little bit involved. Maybe start with sort of an easy question. The question here is really to enable us to understand the audience today that is attending this particular call. And the question is, what type of group practice are you currently working for or representing? And we just picked, these four categories of to assess the size: 1 to 3 physicians and mid-levels, 3 to 8, 8 to 20, and 20 plus physicians as sort of the four options. As you can see on the screen, on a browser, on a separate tab, simply type www.healthsense.com/Q1, and we'll give you guys a minute or so to log in right now. So healthsense.com/Q1, and you'll be presented with a screen that Steve has brought up on the computer right now, where it has those four choices for you. Please go ahead and select one of those choices and hit done. And we'll give everyone a few seconds to take the time to answer this question. And in a few seconds, we'll refresh the page and we'll share so everyone knows kind of who's on the call, what type of practices are represented on the call today. Steve, anything that you'd like to add in terms of guidance to the attendees?
No, just reinforce, if you could take a moment, please, and just simply go, as you see on the screen, to healthsense.com/Q1 and check the box that represents the size of your practice. That would be great. And then click Done. If your practice size 3, don't worry too much about whether you click the first or second box. We're just trying to get, a quick study of the size of your practices. So please complete that, and we will now go take a look at the survey results. Okay, looks like a great outcome here. First, I can tell we have about 25 responses, so let's see what you folks have answered here. All right, Rajesh, the results are in, and you can go ahead and see the distribution.
Great. Thank you, Thank you, Steve. So as you can see from the call today, looks like, not surprisingly, about half or so are, small group practices, 1 to 3 physicians thereabouts. And then you see a big next tier, which is about 25%, almost a fourth, are in that tier of 3 to 8 physicians. And the rest, which is the other quarter, roughly are in groups that are 8+ physicians. So that's a good distribution, and again, it's very much in line with the broad distribution of healthcare providers across the nation, anyways. So it's good to know that that's what we see. So switching gears and kind of going back to the topic, I thought this senior vice president and CFO of a large health system, Banner Health, kind of said it best when he was featured recently in the Health Leaders magazine, talking about kind of the new brave world of healthcare as it applies to healthcare providers as a whole. And you have these things that he was referring to, what we call high deductible health plans or consumer-driven health plans. And for a practice to really be efficient, while in the olden days you really had to get very good at billing the insurance companies in a timely fashion, making sure that you get through, in terms of acceptance of your claims in the first submission, meaning low denial rates and all of the denial management headache. It's now a very different game because not only do you have to fight with the payer, but you also now have to get very, very efficient with collecting from patients. And if you think about it, and you think about the skill sets and the tools and the processes that are involved in billing insurance companies versus billing patients, I mean, it's really two very different set of skills and set of core competencies that we as providers have to build. And clearly, it's not just enough to get good at collecting from payers, but also have to be efficient and have to be very good at collecting from patients, and that's again a very different ball game. So clearly, he's making a call to his peers around the fact that the tactics have changed, the times have changed, and therefore we also have to continue to adapt. Next slide, Steve. So one driving force, as we all know, has been the meteoric rise in the enrollment in high deductible health plans. This is data, by the way, that I took from the nonprofit group called the American Healthcare Insurance Policies. They did a recent survey, and they currently pegged the number at about 20 million enrollees are now covered by these high deductible health plans that also have a health savings account. And you'll see different numbers quoted by different sources. If you look at high deductible health plans as a whole, I think the number is somewhere around 32 to 34 million. And as you can see from the slope of this curve or this line, it's the pace of the enrollment that has certainly got the attention of a lot of people, certainly on the provider side. And one of the facts that came out that really jumps at you when you look at the detailed report from AHIP is the fact that nearly 74% of large employers, and large employers by their definition I think is about 50 employees or greater. What we are actually seeing in terms of enrollment in high deductible health plans goes nearly 74% as of early 2014, nearly 74% of the large groups that offer health benefits to their employees are now offering various types of high deductible health plans and really pushing their employees and their participants to enroll in these high deductible health plans. One of the factors that may be contributing, of course, is this quote-unquote Cadillac tax that is going to go into effect on rich benefits plans. That's obviously not kicking in until 2018 as part of the Affordable Care Act, but certainly that's one of the components of what's kind of pushing these large employers to continue to push enrollment in these high deductible health plans. Some of you may have seen these stats before. This is the latest and greatest in terms of the enrollment data on all of the exchange-based plans. And as all of us probably know, you have these different plan types across, four metallic levels, bronze to platinum on the high end. And you see what the plan pays versus what the consumer pays as a quick visual for you guys on this chart. What you see across the enrollment data is roughly to date, if you build on the next set of bullets, Steve, roughly about 11 million enrollees are now part of the Affordable Care Act. When you look at the stats of coinsurance, the startling fact is that 96% of the enrollees on these Affordable Care Act-based plans, and these could be, by the way, either newly insured folks, or it could be folks that may be working for small businesses that have jumped on the exchange and enrolled their families into these plans. 96% of the time, you have enrollees that have 20 or higher percentage in terms of what their out-of-pocket is. That's the coinsurance levels that you're seeing in these plans. You're also seeing 90% of the enrollees have 30+% of the healthcare dollars coming out of their pocket, and you're also seeing 70%, as high as 70% of the plans, or the enrollees, I should say, have their responsibility being equal to at least 40 cents on the dollar in terms of the healthcare expenses for their families. Clearly, when you see this level of data, it's clearly pointing to the fact that you're only still seeing the first full year of enrollment data on the Affordable Care Act-based plans, and a lot of people believe that we are still really in the infancy stages of how the patient out-of-pocket is going to continue to climb. And when you look at the reality, just broad stroke, this is data from both the Medical Group Management Association as well as a number of think tanks. What you're already seeing is nearly 30 cents of receipts for a practice are now coming from patient out-of-pocket. And this is really measuring receipts, not necessarily including any of the pre-designated charity care, nor including any of the bad debt. But if you purely look at it from a receipt standpoint, almost 30 cents on the dollar for most medical practices is obviously coming from patient out-of-pocket, and that's a very, very different world than even 5 or 10 years ago, where a much smaller portion of your revenue base was coming from patient out-of-pocket, and we've seen all the reasons why that is the case. You're seeing a lot of enrollment in these high deductible plans, employers changing contribution strategies, and of course, all of the stats that we just reviewed in terms of the Affordable Care Act-based exchange plans, being so heavily skewed towards patient out-of-pocket, certainly is. Now, clearly, this varies based on your payer mix and based on your specialty. One data point I'll tell you across our clinics in suburban Chicago, we are seeing on an average almost 40 cents of our receipts are coming from patient out-of-pocket across our immediate care clinics. And we've even seen practices that have even 40, 45% of their receipts coming from patient out-of-pocket. So instead of speaking about broad statistics, I thought maybe just to involve you guys again. That brings us kind of to the second question. And by the way, we've got again the same process. If you just go to healthsense.com/Q2, you will see this question pop on your screen. Just go to a browser in a different tab or a separate browser window. Type in the address that Steve has highlighted on the screen, healthsense.com/Q2, and you'll be able to answer this question. And by the way, I should also highlight that all of the data, all of this question and answers are completely anonymous, so it doesn't even track who is answering the question. And I just wanted to get a live sense of all of the attendees, kind of what you guys are seeing within your practices. So taking 2014 as a baseline, and again, we're not trying to get down to a great degree of accuracy, but just directionally. For 2014, what portion of your receipts or revenue was coming from patient out-of-pocket? And as a reminder, when we say patient out-of-pocket, it includes co-pays that you may be collecting, it includes deductibles, it includes the co-insurance that a patient may be responsible for, as well as all of the self-pay patients, where they may not be insured or have chosen to pay out-of-pocket. If you took all of that patient out-of-pocket responsibility, what portion as a percentage of your total receipts is coming from patient out-of-pocket? So the options are less than 10%, 10 to 20%, 20 to 30%, or 30+%. And of course, if you really don't have the information handy, you can certainly choose the last option, although hopefully you'll choose one of the first four just to give us a directional feel for what your practice is actually experiencing. So let's give folks a couple of seconds to complete that. And
Okay, Rajesh, it looks like we have about 24 responses, so we'll go ahead and take a look at the results.
Great. So this is interesting. I think what we are seeing here is putting aside the folks that don't have the information handy. You're seeing obviously it being heavily skewed towards the 30+% as being patient out-of-pocket, which probably emerges as the first bucket. The second bucket is the 20 to 30% category, and it's surprising that we actually have a group represented here that has less than 10% of their receipts coming from patient out-of-pocket. But this distribution, by the way, is very, very similar, and I think it is also certain that when you look at most practice management systems and most practices, I think I can fairly say that it's not easy to really have this stat jump at you, particularly in practices that are, independent group practices that are doing cash accounting. Sometimes this number is not staring at you as much as you would probably like to and probably need to going forward. But this gives a fairly good distribution of what we expected to see in that, certainly the patient out-of-pocket is continuing to be an important portion. If you switch back to the presentation, Steve. What this is clearly telling us is the patient as a payer is the new reality in healthcare, right? And unfortunately, when you look at patient pay across large, small, and very, very large providers on the left side, you're actually beginning to see very, very large write-offs out of the patient portion. You're seeing higher costs in terms of your cost to collect, and that includes the multiple statements that you have to mail out, the calls that your staff may have to make, all of the costs associated with third-party collection agencies. And an interesting stat that I just saw the other day is if you look at debt collection as an industry, something like 38% of the industry is purely there to collect on healthcare bad debt, which I thought was an astonishing stat that kind of jumped at me when I saw that. And clearly, with the process of first chasing the insurance companies and then chasing this, the patients, you're certainly seeing a significant delays in terms of your AR days. It's very typical for us to see AR days in the 40 to 60 plus days, as I'm sure Steve and his group will also attest to. And clearly it's problematic for healthcare providers. And when you net it out, what we are seeing is a practice is losing anywhere from 30 to 40 cents on every dollar they're entitled to from patient out-of-pocket. And I'll share some of the stats in a little while, but it really is an astonishing stat, particularly for the well-being and the growth of small to mid-sized group practices, where I truly believe a lot of important service and very valuable service is provided to the community, and they are very much an integral component of healthcare delivery here in the U.S. And it's very critical, of course, for this group of medical practices to not only survive but really thrive in the days ahead. And I think in the backdrop of falling reimbursements, all of the administrative expenses, and all of the additional burden on compliance, I mean, we certainly see patient payments as an important area that most practices would want to improve their practices. At the same time, when you look at it from the consumer's perspective, the consumer went from maybe all the way up until 2009, 2010 timeframe, which was only 5 years ago. They went from thinking that if they had insurance, insurance picked up the tab, or insurance picked up the tab on almost everything, to now this new reality where they are responsible for the first $2,500 to even some of the exchange-based plans where you're seeing $13,000 deductibles. So that's a pretty significant amount of out-of-pocket expense. And what we are hearing from patients and what we see every day from patients is they're really struggling with the lack of transparency and really understanding what things cost and understanding what their out-of-pocket expenses on the front end. They generally find healthcare billing to be confusing because you've got statements from insurance companies on one side and statements from providers on the other side. And a lot of these paper statements also results in creating that confusion for the patient, and we'll see that in just a second. Next slide, Steve. So in the backdrop again, when you look at the U.S. consumer population, obviously the population is changing, and where for a practice, you need to think about patient out-of-pocket is largely the bars that are sort of in the middle and to the left. You've got children under 18 years of age. You've got the 18 to 24, kind of the millennial generation. It's actually bleeding between the second bar and the third bar. So the 18 to 34 years of age, the millennial generation. And by the way, some of you might have read this. This is the first year in the U.S. history that millennials have now overtaken baby boomers. So if you look at the charts on the right, the graphs, the bars on the right side, the baby boomer generation, which is those that are 51 to 69 plus years of age, That population is now about 74.9 million of the U.S. Census versus the millennials, which is about 75.3 million. And the Gen X in the middle, those that are ages 35 to 50, again is an additional 66 million. The point of that is, I think while my parents and grandparents may have had a very different expectation and experience that they sought when they went to healthcare, typically to the same family physician that we probably saw for ages. What you're seeing with this demographic shift is a very, very different type of expectations from the consumer standpoint. And if you build the slide, Steve, what you're seeing, particularly in this, the middle, the middle of this chart is those populations that are, 18 plus years. They have their own insurance once they cross, the 26 years or what have you, all the way to pre-Medicare that are largely impacted by these high deductible health plans. They're almost demanding a different degree of transparency, a very different sort of an experience from the healthcare system, a different level of convenience and engagement. And really, when you'll see this reflected in the next slide, this is a slide that actually is portraying, obviously, the broader question, which is, why aren't patients paying, right? I mean, 2009, McKinsey, the big consulting company, and this is often cited in many of the metrics that are used by different groups, they actually did a study of healthcare, consumers, and they polled a very large group of patients and said, what's been the issue in terms of why you don't pay? And specifically, I extracted the portion of the report that speaks to balances below $500 in patient out-of-pocket. And the top three reasons, as you will see, emerge from that, if you could just build the slide, Steve, are lack of financing options, and the other two, which may be more related to ambulatory care settings, which is, hey, I'm either confused about the timing of when I'm receiving statements, or I'm confused about what my out-of-pocket responsibility might look like. And clearly, it's not just the lack of ability to pay, but more the process itself in terms of what's confusing the patients. And therefore, as we all know, the healthcare bill goes to the bottom of the pile of bills. And while mentally they may make a note of, going and reconciling it against what their insurance EOB says, it continues to kind of sit at the bottom of the pile. And we see that continuously, particularly in the backdrop of the recent changes in terms of the credit bureaus not really counting medical bad debt in terms of your credit scores. Clearly, that compounds the problem for all of us as providers. The other interesting stat that jumped at us when we looked at this data is when you look at it from the perspective of who is actually willing as well as able to pay these balances that are less than $1,000 versus those that are over $1,000, which are probably largely from those acute care settings, large hospitals and so on. A very startling fact kind of jumps at you. What we found is that nearly 90% of the patients are both willing and able to pay for balances that are below $500. Steve, if you could just hit next. And this is the stat that I was talking about. Over 90% of the patients are both willing and able to pay for balances. And clearly, when we have seen large medical groups to mid-sized medical groups to even small groups, and we look at the amount of loss that they're seeing, 30 to 40 cents on the dollar, clearly it's not just related to people's inability to pay. And that brings us to kind of the third, and I promise you, the last poll question we'll have besides the open Q&A at the end of both this session as well as kind of the next segment, just to get a feel for, again, what the experience is for all of you that are on this call. If you look at 2014 again, and now that we are on, April, middle of April or thereabouts, and you look at your either the out-of-pocket or bad debt that you have turned over to a third-party collection agency, or you look at AR that is greater than 120 days, the question here is how much of the eligible patient out-of-pocket is either sitting in bad debt or is sitting in AR greater than 120 days. Again, if you could just open a web browser and go to healthsense.com/Q3, you'll see the list of options. And again, we're trying to get a broad stroke feel for what the experience has been of this group. So take all of your AR greater than 120 days plus what you've turned over to a collection agency versus what you actually collected from patients, and just give us a feel for what you're experiencing as being bad debt for your particular practice.
Okay, in the interest of time here, Rajesh, we have
go ahead, Steve.
money in here. And actually, Rajesh, I just wanted to mention a number of the folks have come in at info@HealthSense and find this to be an extremely compelling topic and are very anxious to get your advice on what they can do about this patient collection problem as soon as you can provide.
Absolutely. So it looks like you've got a distribution where almost 50+% are less than 20% sitting in bad debt, and another quarter or so sitting in higher than 20%, and a fairly decent number, about 24%, don't have this information handy. Again, not very surprising. And again, to your point, Steve, why don't we kind of pick up pace a little bit and move fast into the second segment. So one of the things that is leading to this issue, as we talked about, is a large number of Americans are now beginning to complain that they're surprised by their medical bills. Go ahead and build the slide, Steve. Nearly 2/3 have said in this TransUnion Healthcare survey of over 7,500 households that they're actually surprised by their medical bill when they actually receive the bill, and only a quarter actually say that they have received their bill or an estimate prior to treatment, and that's certainly one of the components that you'll see. Next slide, Steve. And while I won't go into all of the detail, this is what you guys do day in, day out in terms of your revenue cycle, the front-end processes, what happens in the middle and sort of the back end of revenue cycle. But one of the important facts that has emerged, if you build the slide, Steve, is certainly when people look at what innovation is most required as a game changer, not surprisingly, the number one thing that comes up is really engagement of the patient on the front end. And if you move to the next slide, Steve, just to give you guys a real feel for what the opportunity might look like. And again, I won't go into this in too much detail. I'm happy to engage with any of you that may have a question. Again, no obligation in terms of looking at the analysis for your group. But even if you take the MGMA standard target of a 95% net collection rate, What you're seeing with the opportunity here in terms of improvement, if you build the slide, Steve, just go ahead and continue to build the slide. For a $50 million practice, there is the opportunity to add as much as $2.7 million to the bottom line, dollar for dollar. You're actually going to see an increase in your top line. And one more build, Steve, and you'll actually see a very dramatic improvement in terms of the contribution of patient, the patient component to your operating profit. And there's not a lot of things that you can do in this day and age when you can add about almost $2.8 million to your bottom line. And again, next slide, Steve. So clearly, patient revenue cycle, and I'm going into sort of the best practices here, is to really apply a new type of thinking in this day and age of what we have talked about all the time. It's obviously, when you look at the revenue source, a lot is now coming from patients. It's not just enough to look at eligibility and say, are they insured, but really to adjust your approach based on what really is at stake. The patient billing component overall needs to turn from a provide service and bill later to both systematic and very disciplined collections on the point of service, as well as having the assurance that hotels and car rentals and other industries have shown with a card on file to have some sort of an assurance or a pre-service deposit on the front end. And doing so in a way that creates a complete transparency to the patient, which is almost being demanded by patients, and typically in a setting that really empowers the patient and really enables this sort of a self-service is sort of the broad headline. And we'll move to the next slide, Steve, and just kind of look at the patient payments, sort of the iceberg, if you will. What all of us see, obviously, at the point of service is, if you build the slide, Steve, co-pays and prior balances, which are great opportunities to collect while the patient is at your facility, in your doors. But honestly, the portion that tends to cause the most friction and causes the most amount of loss is really the residual balance of the patient, and that's the deductibles and the co-insurance or non-covered services that we typically see. And I'll give you some real-world sort of examples of how folks are addressing this patient payments iceberg, if you will. So let me just kind of pause there, and if you could maybe skip a couple of slides, Steve, and maybe take a 2-minute pause before we jump into the best practices. Steve, if you could maybe take 2 questions, if that's okay.
Yeah, very good. So let me remind, because I know a number of participants have joined in process. Excuse me. There are 2 ways that you can go about asking questions. If you haven't done so already, feel free to send an email immediately to info@healthsense.com. That's info@healthsense.com. Secondly, right now, I will free up the phone line, and you may, when prompted, press *6 on your phone to ask a live question, which we would welcome the opportunity to field those live questions right now. So let me free up the line, and we will field live questions. Okay, if you would like to ask a question, please press *6 on your phone now and ask your question. Any live questions? *6.
Steve,
okay, then I will. Oh, is there somebody asking?
This is Regina. I was just going to say I have 2 similar questions, actually. So in the interest of time, we'll ask them at the same time. One is that came through on info. One is that when we call to get prior authorization, we're being told by some payers that the patient is on an exchange plan, and
Yep.
that we shouldn't collect any co-payments up front. Is there any way?
Yeah, great question. Yeah, great question, Regina. And I think this is very symptomatic of what we are beginning to see and actually will increasingly see. And that is, maybe the card will tell you what their copay is, but it's really the deductible and the coinsurance that is the most problematic. And for insurance-based, for the exchange-based plans, the payers, some might call it perhaps intentionally, are trying to be sketchy about providing that level of detail to us as providers. And as part of the best practice, I'll talk about it, but real quick, maybe you really want to begin to think about your patient financial policy and really create a carve-out section that will require your patients to either provide some sort of a pre-service deposit or you collect a payment assurance in the form of a secure encrypted credit card on file towards any patient out-of-pocket responsibility after the payer has adjudicated the claim. And perhaps that's the best form of protection that you can really get so that you don't spend an inordinate amount of time and effort in terms of chasing for the money that should be owed to the practice to begin with, as well as, of course, be assured that you'll get paid for the patient out-of-pocket.
Okay, Regina, did you have a related question?
Yeah, there were two questions that were very similar, so I think that answers both.
Great.
Okay.
Thanks, Regina. So just in the interest of time, why don't we just kind of start with what we have learned, and again, we'll have hopefully time at the end for more Q&A. So the first thing, I guess, in terms of best practices that we see is a higher level of both awareness and accountability in these practices. Typically, not just the large stakeholders, the physician owners or the board, but really having the broader team understand what's going on in the marketplace, understanding where things stand today, as well as what you can specifically do in terms of improving. And a good source is really external benchmarks of, folks like Medical Group Management Association, for example, or the HFMA are certainly great sources of information around creating and using external benchmarks. Speaking of benchmarks, oftentimes we go into practices and we ask them what they use in terms of measuring their effectiveness around patient collections, and one of two things typically come up, right? The first thing we might hear is that they're using gross collection rate, and as we all know, gross collection rates are fine, but in some ways they're really meaningless, right? If you have a gross to net ratio of, let's say, 30% or maybe 40% even, if you said I have 2% bad debt, and that's really a gross collection rate, it's actually very, very misleading, and oftentimes, creates a level of complacency, I believe, than is required, in this day and age. The second metric that we oftentimes hear is the net collection rate, which is better. It's looking at how much is bad debt across all of your total receipts, whether they come from payers, whether they come from third parties for workers' comp or MVA type of cases, as well as the patient. But what I think is really necessary is to create a new metric. I'll call it the patient collection rate or the patient yield, and that is truly measuring what you are collecting from patients versus what you should have collected. And sometimes you could even measure this collection rate net of your billing and collection expenses to really, really tell a story. And again, we won't have a lot of time on this call to maybe go into that in more detail. But if anybody is interested, you can feel free to email me. I'll share my contact info. and we'll be happy to kind of share this metric with you guys and how to quickly look at it. But setting those benchmarks, setting clear performance goals, and really creating an internal cadence of being able to review it as a team, both weekly with your operational staff, monthly with the broader audience, and of course quarterly and annually, is one of the first things that we see in terms of the best performing practices. Next slide, Steve. I touched on this earlier, but an important component is, of course, your financial policy, right? A lot of times we see practices that may have created a financial policy a few years ago, may or may not have gotten around to reviewing it. But again, this is sort of the basic blocking and tackling, making sure that you spell out for those different buckets that copays are due at the time of service, collecting a payment assurance, prior to service, towards deductibles and co-insurance. You may want to spell out as a clear policy that you have. And ultimately that the patient is taking responsibility, which usually is, fairly well covered, in terms of most financial policies that we see. It's really the dissemination of that is where we sometimes see maybe not a great level of adoption. And, the last item I would mention is, of course, making sure you get counsel to properly word it in the right legalese. But making sure that you are communicating this financial policy clearly to patients, both through your website, reiterate it during the appointment setup, as well as at the time of check-in for visits, and really also reiterating it even post-visit as part of your statementing process.
Eastern time. It was started at 2 o'clock Central Time.
Steve, I hear a little bit of background. Great. Thank you, Steve. The third one we'll go to is, the scheduling process itself. A lot of what we see is improvements that folks have made around their appointment scheduling process to make sure that they're collecting data from particularly new patients as part of the appointment setup, using that as an opportunity to reiterate the financial policy based on what type of insurance a particular patient may have, reiterating as part of the appointment what you need to bring. And again, we know this is just making sure that people don't have excuses when they come in, and not having a credit card, for example, or not having the ability to take care of your both copays as well as any kind of deposits or payment assurance that you might require. Reiterating that, and most importantly also is making sure that the check-in process itself is much more quick and easy for the patient. Moving on, the fourth is really this time of service excellence. Again, this is preaching to the choir a little bit, but it's sort of the fundamentals and making sure that they are right in an increasingly competitive space. Making sure that the patients feel welcome, they are received in a friendly and compassionate manner. One important aspect that oftentimes gets overlooked is, like it or not, we now have the responsibility to educate the patients on what their plan really covers or doesn't cover. And very few times we see practices equipped to be able to have this level of conversation with the patient. But the more, obviously, we are doing to both educate them on what their out-of-pocket is, and then immediately also make sure that we enforce our policy around collecting copays, prior balances, and any kind of pre-service deposits towards that deductible and coinsurance, is really this notion of time of service excellence. The fifth one, which is very related to both the payments due at the point of service, but more importantly, very much important for the residual balance is embracing this notion of transparency, right? I mean, like I said in the earlier slides, it is almost being demanded by patients. A lot of the forward-thinking practices really embrace this notion of no surprises policy and never to bait and switch patients, and to be able to provide clear and concise estimates of the applicable costs, meaning the patient out-of-pocket costs, and particularly when you're dealing with pre-service estimates, for these high-ticket services, things like, diagnostics or procedures and so on and so forth, being able to generate a pre-service estimate that is directional, not necessarily down to the penny accurate, but making sure that you are providing the sort of an estimate before service is rendered. At the same time, one of the things that I think all of us probably experience in healthcare is sometimes you get a bill many months later or many, many weeks later, and it literally is a black box from the time I go see a physician to the time I get the surprise in the mail. And what you're seeing increasingly by the best performing practices is not keeping the patient in the dark till after the insurance adjudication cycle goes, and almost providing for those cases where at the time of service you don't know what service may be provided to the patient, like the typical E&M consults, for example, but really providing that sort of a preliminary estimate to the patient. And remember, when you look at most folks that are on this call, your pricing may be a huge competitive advantage for you compared to what an MRI might cost at a large system, or what even the basic consult might cost, versus at a large system. And transparency doesn't mean anything more than really giving yourself the ability to hold the patient accountable financially for what the care that they're able to receive. And that really brings me to the next slide, or the next best practice that we see is, this notion of collecting payment assurance on the front end, right? I mean, like I said, hotels do it, car rental agencies do it, and it's really time for us as an industry to be able to adopt the same sort of a policy and not have to go chase patients for the money that is owed to us. So a lot of them, and many of you guys may also be doing this, is requiring deposits on the front end for particularly new patients, or those things that are like diagnostics and so on that may be involved. I think there's fantastic technology now that has not just from us, but many players that help you implement a very secure, industry compliant, payment assurance type of mechanism, so you can keep a card on file or an ACH on file and use that as a way to settle the residual balance of the patient. And an important aspect of this is, for those practices where you may have not just your E&M consults and so on, but a set of ancillaries, perhaps based on the appointment time when you secure this payment assurance on the front end towards settling the residual balance, you set a limit in terms of like hotels do when you check in, where they say, hey, it's a $200 deposit that we are going to draw. And they're all not really drawing the money. They're just sort of putting a hold, if you will. And while in healthcare you can't put money on hold, it's more, symbolic in nature and really a deterrent for patients, when they provide this type of service. And we've seen many practices that have embraced this notion of, I'm going to be upfront about what your cost is, but in return, I'm going to, as a policy, require you to provide this sort of a payment assurance. And by the way, you don't need to do this with patients that are on Medicare or Medicaid, or some of those third-party situations like workers' comp and so on. It's really the commercially insured patients that require this, type of diligence on our part, and creating a payment assurance is one of them. The seventh one, in terms of best practices, is really offering multiple payment options for patients. You see that in terms of credit cards, debit cards, ACH, so on and so forth. Clearly, electronic payment options reduce both your cost to collect as well as the risk to you, in terms of having that assurance to be able to settle the residual portion. And while this may not necessarily apply to this group, another one that we see is examples of folks like Care Credit, where you will get paid, on the front end of what is due to you, and of course, the patient is financing it to a third party in terms of how they pay it over time. Eighth one is, I think you're seeing, the culture of a McDonald's or, what Apple has been espousing for many years, is really to think about the patient experience. And to us and to a lot of the pundits in the industry, clearly patient experience besides clinical excellence is a very, very strong differentiator, in terms of where the world is headed. And I think when you think about the patient experience, you got to think about the end-to-end experience of the patient, from what it takes for them to get an appointment with you, to what happens at the point of service when I show up, to how you are educating and really engaging me in terms of my patient, my financial exposure. And at the end of the day, build a level of convenience and trust with the patients. And I think there's a lot of good stuff that is going on around, patient experience aided by technology. And speaking of technology, maybe I invite Thirumal to just give his comments in terms of, the right technology for this purpose. Thirumal, are you there?
Yes, I'm here. Glad to be here. Good afternoon, everyone. So now that we've gone through all the backdrop of why we need to effect a change and gone through all the best practices, let's see how we can make this very effective. Wish I have a magic wand, but we can certainly explore the best possibilities here. I think as again, going through all the recommendations and the best practices, that helps us get better organized in how we can better respond to these challenges that Rajesh has alluded to. It is almost certain that in this day and age, there is only the technology-driven approaches that can yield optimal results, as we have seen across all other walks of life. So the solution and the approach, need to really deliver a systemic execution of all the improvements and suggested recommendations that we've just kind of reviewed together. That can not only help you collect, what's rightfully due at point of service payments, and also to help you optimally collect and improve that collection rate for all the residual balances post-insurance adjudication. So, that'll alleviate, a technology-driven approach obviously alleviates, all other bottlenecks that are otherwise caused due to any manual, process and intervention, right? So as you may have noticed, of course, I come from a heavy technical background, and I'm sure I think you would only expect me to give you the best guidance as possible in helping you select the right technology approach. The good news is that there are, a handful of such approaches that, we can choose from today. And, the first thing is that, most of the practice management systems, that most of you are familiar with, have certain extensions to help you in this patient revenue cycle management, but, most of them woefully fall short in this aspect. And none of them, have, the best approaches that, at least based on our experience. So of all the research that we've been doing across last several years, we are very convinced that, the best of breed approaches and, what I call the solid bolt-on solutions are the best fit to address the patient side of the revenue cycle management functions that we just have been talking about. So choose a solution, that has a distinct approach to put the patient in front and center of a self-service driven engagement model that we, as consumers in all other walks of life continue to expect and demand. So the same experience, need to be delivered in healthcare settings as well. And it's also critical that you choose a platform, that does not interfere with your patient workflow, or clinical workflow rather. So this is very important that, you don't impede the patient check-in experience, at the front desk. Some approaches that we have seen, handing off these tablets at the front desk, ask patients to come about like 15 to 30 minutes in advance. So, those also appear to really interfere in the patient experience and interfere in that patient flow. So therefore, the solution you choose to deploy should allow ease of use for patients with a very, quick patient check-in process to deliver that what I call seamless user experience, almost like a zip check-in at, the airport kiosks that we all have been used to in our walks of life. Last but not the least, you want to pay attention, while you deploy a technology approach that ensures strict adherence to regulatory compliance, such as, HIPAA and PCI, in the payments industry. So therefore, I think, now you just, get a good feel that, right technology approach can yield optimal results, if you choose right bolt-ons that can, very well interoperate with your current practice management systems. Back to you, Rajesh.
Yeah, thank you, Thirmal. Last but not least, in terms of the best practice, number 10 is really looking at your payer contracts to the question that was asked earlier around having the flexibility to the extent that either you individually or collectively can begin to represent our local industry groups like MGMA, for example, have great forums, if you will, that you can use to express collectively your needs to the different payers. And an important aspect of that is this enhanced eligibility data, whether it is, around the pre-cert, pre-auth process, or even just eligibility. I think there is a lot to be desired in terms of greater visibility to you as a provider that are taking on all of this risk to serve the population or the subscriber base of a particular payer. But these plan variations, as we know, can have a very significant impact to your bottom line. And hopefully, those 10, I know we kind of covered it, real quick as we kind of went along, but hopefully this gives you a good feel for what some of the leaders are doing in terms of optimizing patient receipts. And I think the time is now, as well as, the capabilities are there through a number of tools that are out there that can really help you increase your patient yield or improve your patient net collection rate. And with that said, let me just, I guess, turn it to you, Steve, or Regina, I guess, in terms of the next, 10, 11 minutes in terms of any questions that folks might have.
Okay, first, before we poll Regina for questions that have come into info@healthsense.com, I'd like to offer the audience the opportunity to ask any questions that you might have. This will be the final opportunity to ask live questions. To do so, simply press *6 on your phone keypad right now and go ahead and ask your question. Going once, going twice. I will ask one more time, but in the meantime, I will turn the floor over to Regina, who has indicated we have several questions in at info@healthsense.com.
Yeah, so this first question kind of goes back to our previous Q&A. It came in like right after we shut things down, which is that okay. Can you address collections with regard to grace periods for exchange plans? Apparently, there's one practice mentioned that they have a situation where patients came in and they gave them the insurance information, but they hadn't paid their premium. So there was I guess they were under a grace period.
Correct.
And I don't want to share too many details about the specifics, but it had to. The question revolves around when you are confronted with a patient who's in a grace period.
Yeah, and that obviously throws another curveball at us as as a practice leader. And I think overall, clearly, the governmental policy is the governmental policy. I mean, that's the set of cards that we are dealt with. What I would say is, I think going back to this discussion about the financial policy, at the end of the day, as a healthcare provider, but really as a business, you're providing a set of services to a consumer, and ultimately they are responsible for the financial obligation that they have, regardless of whether they have insurance, whether they have a particular type of insurance or what have you. I think the best way to address that is to enforce this sort of a payment assurance on the front end, and you can, of course, as a favor to the patient and as a service to the patient, you will, of course, file a claim with the payer, wait for it to be adjudicated and the determination made around what the patient out-of-pocket is, and only then go charge the patient for the card on file that you have secured. Unfortunately, that's a situation where you would have to, a business as usual approach obviously is not gonna help, right? I mean, you're gonna have to do something a little different and out of the box, either requiring a deposit or requiring a card on file assurance on the front end to be able to address those type of scenarios. But there's really no workaround, so to speak, around the grace period rule.
Yeah, and I might add on the grace period, typically the way this works is during the first 30 days of the 90-day grace period, you have the opportunity to collect directly from the payer as well as to collect from the patient. However, once you pass that 30th day, for the next 2 months, your only recourse is while the patient is still insured via that 90-day period, you can only collect any payments that are now due after the first 30 days from the patient themselves, at which point, if they don't pay it at the end of the 90 days, their coverage expires. So, it's really critical, back to the points that both Thermal as well as Rajesh have made, that your systems, in light of the emergence of exchange plans, track and, precisely these grace periods. And otherwise, you're going to lose the opportunity, collect from payers, and then subsequently, your leverage is going to go down if that 90-day expires and you still haven't collected from patients. Okay, Regina, do we have other questions coming
Just
in?
one more, and it's kind of an interesting question, actually. Would you consider it a best practice for patients who have large balances to put them on a payment plan?
Yeah, so unfortunately, there's no one answer to that. It's one of those, it depends. But typically what we see is, at least we do this in our clinics, if you're asking for a 3-month recurring plan, provided that you provide us a credit card on file, again, encrypted, secure, so on and so forth, we are okay to act as a bank for those exception cases, for the first 3 months. If it is anything beyond 3 months, I would really encourage you to look at a third-party financing option and bring in a care credit, or there's a number of different vendors like that out there. And that way you will get paid, and, the finance risk is really then borne by that third party. Three months, maybe 6 at best, but nothing beyond that would be my recommendation.
Okay. Good.
Okay, very good. Regina, do you see any other questions?
I do not see any other questions coming through.
Okay. One that I saw flash by, I'll go ahead and ask it because there may be individuals in the group that don't have this background, but one of the individuals wants to know what an insurance exchange plan is. Would you like to comment on that, Rajesh?
Yeah, so these are plans that are offered by most large insurance companies on healthcare.gov. So obviously each individual state has their own exchanges, or some of the states have chosen for the federal exchange to effectively be in effect for their states. But it's an open marketplace where either individuals that want to buy their own insurance or employees of small businesses that may have been encouraged by their employer to go buy insurance off of these exchange. And all the major carriers, the Blue Crosses, the Aetnas, the United Health Groups, so on and so forth, as well as, depending on the state, many of the, maybe state level or regional level payers are offering insurance plans. And those insurance plans, by the way, have not only this grace period that we just talked about, which is one twist, but also largely, as we covered at the beginning of the this discussion, they largely are high deductible, high coinsurance type of plans in exchange for quote unquote low premiums, and effectively, the insurance companies have pushed more of the out-of-pocket responsibility to the patient and moved the financial risk of collecting that money from those patients, if they happen to be at your practice, to you as the provider. And it's become very, very popular. You're now at about 11.5, almost 12 million enrollees, individuals that are enrolled in these exchange-based plans. So if you haven't seen them, you certainly will. You certainly will in the coming months, and you'll certainly see that increasing, unless there is, of course, a big change to the Affordable Care Act. You'll actually see more and more of these exchange-based plan enrollees.
Yeah, and Rajesh,
Steve, anything you want to add?
We have one more question on the chat.
Sorry, just to reinforce as well, Rajesh, in the beginning of the presentation just mentioned that he laid out very nicely a summary of the kinds of exchange plans ranging from platinum to bronze and the corresponding patient obligations. And one thing that is uniform, regardless of whether it's a state or federally run exchange, is the reimbursement structure of those plans. So I encourage you to take a look at that. Go ahead, Regina, and ask the next question.
So the chat was, why would you not be able to collect a copay up front, as someone previously asked?
Yeah, copay is not the issue. Copay you can and should be able to collect at the time of service. It's really the portion that is applied towards the deductible or the coinsurance after you submit the claim, after the payer processes the claim, that is really the issue. So if it's a simple copay-based plan and all you're doing is a consult and it doesn't apply towards deductible besides the copay, you're fine. It's really the coinsurance and the deductible that cause the problem with both exchange-based plans as well as all commercial insurance plans.
And if there's
no
co-payment required for certain services, then all you're left with is the deductible or co-insurance, right?
Correct. Yeah. Thank you again, everyone, for joining us this afternoon. Thank you, Steve and Regina, for hosting us. And if any of you have any questions, feel free to email me, and HealthSense will make this presentation available to everyone for download.
Yes, and
Thank you again.
I would like to thank both Rajesh and Thermal for their participation in this webinar series and all the valuable information about patient collections and the 10 best practices for collections. This should help everyone who participated to optimize their collections and improve their collections processes. What I'd also like to remind everyone is that Quill Healthcare is indeed the sponsor of these valuable webinars, and in addition to providing an outstanding product line of medical supplies and office supply products, they are offering you a discount for your attendance in these webinars, and the redemption coupon is up on the screen and will be included in the chart deck that you'll receive as well, and I'll explain how you get the charts. But Quill is very focused on providing outstanding assortment of products, outstanding customer service, and as you can see from these webinars, bringing you additional value to help you maximize the returns in your medical practices. As far as obtaining the charts or asking additional questions, I mentioned this up front, and I want to reinforce that you can send any questions to info@healthsense.com, and that will also apply to Rajesh and Thermal. Go ahead and send those in, and we will be happy to reply to those after the session as well. And starting now, you can actually obtain copies of the webinar by simply going to www.healthsense.com/copies. You'll receive a PDF version right away if you go to that URL and simply fill out the short form. The actual webinar in its entirety, with the recording and the video, will be available by the end of the day tomorrow. So you can go back at that time to get a complete copy and to listen to this recording at your leisure. And last but not least, I'd like to ask the participants if you would be kind enough to take a 1-minute, I've even reduced it from 2 minutes to 1 minute, survey at healthsense.com survey, and that's simply to help us understand the value that you derived out of this session. It also helps us to improve these webinars as well as future webinars that are offered. So would really appreciate it if you would take a moment and go to healthsense.com survey on your way out of this session. And I want to thank, most of all of you for participating in this webinar series, and we wish you the best in running your practices. Thank you for participating. This ends today's webinar.